I'm Dr. Pang Hong Wu. I'm from Singapore. Today, my topic is a narrative review and clinical applications of lumbar endoscopic spine surgery. Some of the talk has been covered by Dr. Mohammed. In my practice, I do 40% open spine and 60% endoscopic spine. My fellowship training is with Nori Ganam, so I do an endo Ganam style. I'm fortunate to have both uniportal mentor of Dr. Hieu Sung Kim and biportal mentor of Dr. Ho Dong Hua. I have very good exchanges with several mentors as shown in the middle of the screen. I thank them for that. You can see some of the expansion of the talk in this article that we have written together. Is published in the Neurospine in June 2020. The aim of endoscopic spine surgery is to provide safe and targeted access to the compressive pathology with minimal soft tissue trauma, while performing what we want to do, decompression or fusion. Three key components help to achieve this objective: a magnified visualization from an endoscope, a working channel that's allowed customized endoscopic instruments to bypass soft tissue trauma and directly to the operative field that are causing compressive pathology, and a constant inflow and outflow of irrigation system that allow clearance of debris and clarity of vision. So in the recently, there is some renaming of several ways of performing endoscopy. Essentially, we have renamed them into the discectomy group, the lateral recess decompression, and the Transkambin lumbar interbody fusion, as well as the interlaminar approach, where we have also labeled as discectomy, lateral recess decompression, bilateral decompression, and contralateral approach, as well as biportal surgery. The common current indications, part of it covered by Dr. Mohammed just now, is that for herniation of disc. And the most common indication for transforaminal approach is for contained and low-grade migration. There is advantage of local anesthesia and perform under local anesthesia and moderate sedation, particularly in the L1 to 5 region, for central, paracentral, and foraminal region. There are three ways of doing it: inside out, which I felt that is like dock, and then we float out to find the fragment. Outside in is a foraminoplasty, creating space and find the docking point, and finally a mobile outside in technique. From an inside out approach, if we dock well onto the target, is calm and serene, there's not much epidural bleeding, you can straight away get on to do the discectomy. However, when we have wrong docking, we can actually get into trouble and really fraught with surrounding danger. While on the other side, with a targeted docking, after initial discectomy, then we can withdraw back and look at the epidural space and perform the fragmentectomy. I think the main disadvantage is that there is existing nerve roots is close by. Without foraminoplasty, there is limited real estate and hence might lead to existing nerve root dysesthesia. Outside in technique is more of using a foraminoplasty to create space for docking. And after a sufficient space for docking, we can have a better access and better opportunity to prevent existing nerve root injury. The classic outside in technique popularized by Dr. Thomas Hoagland is to basically do a foraminoplasty, increasing the ventral SAP, getting rid of the ventral SAP, and also a small amount of pedicle to create space for the docking. This reduces existing nerve root injury, and there is some further modification. One of them described by Professor Chu Li is the foraminoplastic superior vertebral notch approach, which I recently used in my institution because of hypertrophic SAP. We use this SVN approach technique to increase the foramen size and take out the superior rim of the pedicle. We have a very good view of the disc and the epidural space. Other similar endoscopic foraminoplasty also described by my mentor, Professor Kim, as a suprapedicular circumferential opening technique. Mobile outside in is like floating a boat to the dock. And for beginners, sometimes it can be disorienting and it can be fraught with danger. And it is an endoscopic assisted foraminoplasty essentially. With visualized reamer and drill, there is an added advantage of being safe when we perform our foraminoplasty. The advantage of that is that we can actually plan an intervertebral route, a foraminal route, or a suprapedicular route, looking out for the disc along the way, and minimize other soft tissue, unnecessary soft tissue trauma. Subsequently, we do what is quite similar to inside-out technique. We do docking into the Transkambin triangle, remove the disc, decompress the disc, and then look for the fragment. This is an example that I've done using a mobile outside-in technique, a patient with bilateral sciatica and neurological deficits with a right L3-4 prolapsed disc with quite a significant canal compromise. It's done under local anesthesia with indigo karma injection. We use under endoscopic technique, foraminoplasty performed, and then we can find the disc fragment by the herniatomy site. Perform some internal decompression first to create space for our working cannula. Subsequently, remove the main big fragment, which I will move forward a little bit and show. And more importantly, like what Dr. Muhammad said, we will have to look at the epidural space and ensure that it's free pulsating nerve root. And using this technique, the patient can go home on the same day with a local anesthesia approach, and we can check that the patient has a good recovery from a discectomy. This patient also subsequently have a teleconsultation and doesn't really need to physically see me because of COVID period. He was locked down in the dorm. So there are some expanded indications for transforaminal approaches, such as high migration disc. We can use, as we mentioned, mobile outside-in technique. Sometimes we can drill the pedicle and directly access to the disc, or we can do the foraminoplastic technique and partial resection of pedicle and facet complex as described. We have seen a case by Dr. Muhammad about the revision discectomy and agree that this is a good approach for revision discectomy, and we can avoid fusion, which is a plus for many patients. Spinal stenosis, we have to take it with a caution. I felt that it's good for unilateral asymmetrical lateral recess stenosis. It is technically challenging, especially if you do it under LA. It can be quite time consuming, especially if a patient have a very tight foraminal stenosis. They might have a chance of exit nerve root palsy, but if done well, many of the papers have shown that they have very good results. Transkambin fusion over the talk or over the next 2 days, you will see there are a few ways of performing endoscopic fusion now. The main advantage is done under LA and is facet sparing, but there's some disadvantage of subsidence and exiting nerve root injury with expandable cage and cage glider usually necessary for the fusion. For interlaminar approaches, we know that it's good for L5S1 with a high iliac crest, especially in male narrow foramen. Especially in L5S1, we have a wide interlaminar window, and many of us are familiar with this approach through our microscopic learning during residency. This is a case that I've done recently. The patient, a 24-year-old man with a listing and a painful antalgic gait. So the patient have a caudally migrated L5S1 prolapse disc. So I perform interlaminar approach. I drew a little bit of the caudal lamina, sparing the facet, creating space, and at the same time, able to access to the caudal migrated disc. With a nerve root retraction and advancement and rotation of the working cannula, we can protect the nerve root and retrieve the disc effectively. We first do the fragmentectomy, and then subsequently we work on to the intervertebral
internet slowage. Slow down.
Thank you. I think we have lost Dr. Huang.
Yeah.
Dr. Pang.
Okay. I
Looks
believe
like
we
he's
have.
back.
Yeah, whatever. I
Dr.
think,
Huang, your sound is muted.
yes.
Your sound is muted, Dr. Huang. Dr. Wu.
Dr. Wu, your sound is muted.
Yeah, I'm back.
Yes, please. 3636.
Can you hear me and can you see me?
Yes.
Yeah, Dr. Wu, please hurry up.
Can
You're
see
in
my
the last
slides?
minute now. Yeah, please hurry up. Please hurry
Okay,
up.
sorry. Okay, I just get started. Okay, so now I go on to the interlaminar bilateral decompression. So basically, this is a technique that Prof. Kim and I wrote up on proctorship. And this is a recent case. Two-level decompression can be done using bilateral decompression. We like to use the outside-in technique. The advantage is that we keep the flavum on most of the time, preventing epidural bleeding. And we can actually have a good, using endoscopic drill and energy, we can assess the flavum clearly to the edges, and then we can retrieve it as a piece. So this is L45, and I will skip to the L34 part so that we can see that as a, because it's quite repetitive. My mentor used a one incision technique. I used two incision. I think for beginner, it's good to use two incision to get to the V point more clearly. So we can retrieve it as the entire piece. I think that's a good advantage, and then we can have a clear visualization as we retrieve that. I think give maximum protection of the dura when we can do bilateral decompression this way. We can use one incision for two levels actually, with a slight cranial caudal to cranial.
John, if you could look into the link, but I think we are running out of time with Dr. Wu.
Okay, I'm sorry. I don't know why I keep putting out. I think I will finishing up soon, just a couple of minutes. You all can hear me?
Please.
Yes.
Yeah, so I just finishing it up. Sorry about that. The contralateral approach, you can read our papers on it. And then this is the final one. I just wanted to highlight with biportal. I think essentially the difference is it is a floating technique. We have a decoupling of visualization and instrumentation. We have a similar irrigation pressure, good visualization, and we can perform most of the interlaminar surgery with spine equipment that we can use in open surgery such as osteotome and high-speed drill. So this is a good way of doing another technique if we have resources limitation, or we we are more familiar with the biportal approach. It's another way I do my interlaminar decompression. Sorry that I take up a bit of more time, and I will finish up soon. The advantage of biportal surgery is clear, similar to uniportal in many ways. I think both have its advantage and disadvantages. Most of them show better result than open microscopic surgery. And we have also published our data on uniportal endoscopic fusion. Can be done in spondylolisthesis, severe collapsed disc space, or adult degenerative scoliosis. You can read them online. And this is a recent paper we published on systematic review of complication. I think the initial learning curve is tough. However, with good perspiration and a little bit of inspiration, sometimes my mentor, I have a mentor from Prof. Kim and Prof. Hao Donghua, we can overcome this. And I think this is the way to move forward in the future. I hope all of you are in good health, and I welcome you to Singapore one day to meet physically once COVID situation improves. Thank you very much. Sorry for the interruptions for a couple of times.
It'll be a pleasure to meet you, Dr. Wu.